Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. Tonight we're going to talk anterior segment cases, enough pearls to make a necklace. It's a synchronous virtual course with my partner Greg Caldwell as the presenter. He's a graduate of the Pennsylvania College of Optometry, where he completed a one-year residency in primary care in ocular disease at the Eye Institute. He's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, a member of the Optometric Glaucoma Society, a member of the Optometric Wellness and Nutrition Society. Currently works in Duncansville, PA as an ocular disease consultant. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease. He's been a participant in multiple FDA clinical trials. He has integrated nutrition, prevention, and wellness into his patient care. Thus, he practices integrative optometry. He's a co-founder of Optometric Education Consultants and co-owner and a co-administrator of OCT Connect on Facebook, that wonderful reference for all our colleagues. He's lectured extensively throughout the U.S. and over 13 countries internationally. In 2010, he served as the president of the POA and served on the AOA Board of Trustees from 2013 to 2016. He's president of the Blair Clearfield Association for the Blind, and in 2023, he was listed as one of the top eye doctors in the U.S. on Newsweek magazine. So with that, a warm virtual round of applause for my friend and partner, Dr. Greg Caldwell.
Thanks, Joe. Thanks for the introduction. And I'll be retiring from that presidency here pretty soon. It was a 14-year run. We got them financially solidified for that Blair Clearfield Association for the Blind. And we got them a building.
Interesting, Greg. You know, Greg, 14 years. At what point does it cross over from being presidency to dictatorship?
Yeah, oligarchy is what we had. So, but anyway, yeah, we've got them the building that they wanted and financially sound. So time to wrap that one up. So, all right. With that being said, here are the disclosures. I always say, look, I don't put this list on here to impress everyone. How does someone in Duncansville, Pennsylvania, have the honor and pleasure to lecture to colleagues? It's because I stay plugged in. Going down through here, I think the third bullet point from the bottom, the content in this activity of this presentation was independently prepared by me. No one asked me to say anything here. If I do mention instruments or products, it's without commercial bias. I'm not claiming superiority. Just sometimes you have to mention things. But most importantly, up here at the top, it says all relevant relationships have been mitigated. I am going to use a lot of more of the disclosures. I'm going to be using a lot of video here today, or presenting video. This is the device that I use, a Firefly by Efficient. I'll show a couple OptiView, OCTA. Again, not claiming any superiority. It's just people will ask, and then I don't have to really point it out anymore. So here are just out of the disclosures part. Here's my practice. Here's the building that we have. We have 5 ODs, who have electronic records, optical contact lenses, so on and so forth. What I always point out with Joe and I is, science is great, but if it doesn't have a clinical application, Joe and I go to OGS yearly, the Optometric Glaucoma Society. They're growing ganglion cells in petri dishes and trying to stress them and trying to make them neuroprotective and all that. And that's all kind of cool, makes us feel good that they're doing that. And it gives me confidence whenever I speak and talk about glaucoma, but doesn't have a clinical application. What we're going to try and do tonight is just cover some things with clinical application. So with that being said, I'm going to launch the first poll here. And pretty easy, yes or no. Have you prescribed Xdemvy yet? Have you tried it in your practice? This is for Demodex blepharitis. Have you tried it yet? Just curious.
As you talk about this, Greg, before you leave that topic, because I know what you're going to be talking about, if you can share some pearls with getting the medicine into people's hands/eyes and coverage, then people will probably appreciate that.
Yeah, no problem. Yep. All right. Looks like we have 7 out of about 100 people, 102 in here. So I'll share the results. You guys can see it there. And we're going to talk real quickly. I'm not going to get too deep into a lot of We want to just be able to recognize it. I'll stop sharing here. So, Demodex, you can see here on this patient here, you can see the blood vessels, how they're injecting, kind of going down to where the condition is or the disease is. Collarettes are the pathognomonic sign of Demodex. And I really think, you kind of have to have the patient look down. Sometimes if they're looking straight ahead, you might not be able to see those collarettes. So one of the things that the company really pushes, and I agree with, is have the patient look down, and as they look down, you're able to see this kind of waxy material that's out there. And Joe Lake knows one of my favorite things. I was sitting with the scientists. I was at one of their KOL meetings in San Diego, and they had all these scientists sitting around. They were going over all this stuff, and I just literally said to them, I said, "Look, isn't this stuff just Demodex poop from these overabundant type of Demodex mites that are hanging out in the follicle down into the feeding off the oil?" And they were like, "Yeah, that's pretty much if you want to put it that way." And we all know that, that can be an irritant. So that's the way I kind of look at it. And I show it to the patient. And probably my best way of doing it is with that slit lamp camera, taking a picture, showing it on there, and they usually want to get rid of it. So, let me just kind of play this video here. I thought maybe it's out of order here. Let me come back to that. I want to kind of show you, what this looks like. And I apologize. These are pictures of a picture that I was just sending to a couple friends. Here is a, before picture. And you can see the collarettes, the Demodex poop that's building up on the eyelashes. See a little bit red and irritated. The patients just don't want to see that. And you can kind of see when I take the photo, I have them looking down, and we have 3-week follow-up down here. Now, this medication is prescribed twice a day, and it says for 6 weeks. That's if you want to be on label. If I was doing a dinner program for them, I'd have to say, look, you do twice a day for 6 weeks. I'm not doing a dinner program for you, so I can tell you what I do is I tell them to use it twice a day until the bottle is empty. You would think that you'd be able to stop at this point. Look how clean and pristine these eyelashes look. That is correct. You probably have paralyzed and gotten rid of all the mites. You got rid of the poop, as you like to hear me say, but there's still some eggs around here. So that's why you want to kind of go that whole 6 weeks on there. The life cycle and all that, when you talk to the scientists out there, is however it is, it's born, it's grown, and so on, how long it takes the eggs to hatch. And that's pretty much why I just do, hey, twice a day until the bottle is empty. And then we're, pretty much guaranteed to get rid of the mites that are in there, or at least reduce them to a more, normal amount. Remember, these are, parasites that do live on our body, kind of homeostasis, and they just kind of get out of hand. And what we're trying to do is bring them back. And here's just another case. Again, 3-week follow-up. I just pretty much tell the patients, look, I don't know, it's a pretty safe medication. The way it works, it's working on, I think it's the calcium GABA channel, which is only found in the mite. So it's really safe because we don't have that type of pathway in a human. But I still say, look, when they do these tests and they do these studies, there's only 200 people in this arm and 200 people in that arm. And so you don't maybe get the side effects. That's when a lot of the side effects will show up whenever you start using it in the masses. So I just say, come back in 3 weeks. And you can see here again, look how red and irritated. You could see the collarettes, how they built up, just the pathognomonic sign, and nice and clean in about 3 weeks, maybe a little bit right here. But 99, like ivory soap, 99%, clean here. Now I think what I'm going to do is I got them out of order. You can see here, I showed this gentleman here. I'm going to play the video. I'll play it to the end because I always ask them to say, look, can I share this with the audience? And Joe, let me know if you can hear this whenever I play it. I think I have it all hooked up for sound. All right, everyone, I'm here with Michael, and Michael's given me permission to do this video. We can see here he's got a pretty good amount of Demodex blepharitis. This is a little bit over 3 weeks, maybe right at 3 weeks. you can see that he had a pretty good overgrowth. He's got a nice improvement on the right eye. Here's the left eye, and then a really good improvement over here on the left eye. So 3 weeks, we got 3 more weeks to go. And here's Michael, and we were chatting about, Mike, why don't you just tell me how your eyes felt and how they feel now?
At first, it was always seemed like there was something in my eyeball that I wanted to scratch them, itch at them, and everything. With now, throughout the day, it seems a lot better, and I don't want to mess with my eyes as much anymore.
The drop is twice a day. We're going to do it for 6 weeks. Does the drop sting at all? Does the drop irritate your eye at all? Is there anything with the drop or is it just a comfortable drop?
No, it's a very comfortable drop, no irritation whatsoever.
Great, perfect.
Yeah, it's good. I love it.
All right, perfect. Yeah, easy treatment. It's not chronic. We'll be done with this in a few weeks, and who knows? Maybe we'll come back and we'll treat it in a year or two. But at least we got a solution for it.
Yes, absolutely.
All right, bud.
That's great.
All right, thank you.
Thank you.
So one of the things that I picked up from him whenever treating a lot of these patients, I probably now treated 25 or 30 of these, and they all don't realize that their eyes were itching before, so that's, I'm not going to say all 25, but a majority of them, they say, yeah, my eyes feel better. I didn't realize that, that they were itchy, and, that collarette material is an irritant, and it probably over time becomes a chronic type of allergy, in my opinion. Remember, there's 4 types of allergies: type 1, 2, 3, and 4. Type 1 and 4 are the ones that affect the eye. The contact dermatitis is the 4. It's the ones we always see people using the different creams, and they get that leathery appearance. And the pollen allergy is the type 1. This is probably like a form of chronic inflammation down here, and then they have the itch. So I would say it's more of a contact type of dermatitis that's out there. So with that being said, go ahead, Joe.
For the audience, don't even try to deal with allergic conjunctivitis or dry eye disease if this is here and you don't address it. You really need to address it. And Greg, you made a great point when you said take your slit lamp camera and and show them what they look like. Now, if you don't have a slit, I agree with that completely. If you don't have a slit lamp camera, what I will do easily in the office, I just pull up Google images and I pull up something and say, you look like this. But really the kicker for me, or what I think is the selling point, is when I pull up an image of the organism and they see what I think it looks cute, but even better, like the high resolution, high mag microscopy. That really sells it. And they realize that's all over them. They're willing to take care of it.
So I see a question rolling in here, and I have them up here, but you can help me police them. And and the name, someone asked the name. Looks like Audrey asked the name of the medication. It's Lotilaner. Ophthalmic, it's 0.25%, and then the branded name would be XDEMVY. It's really the first to the market that's out there for this. You could say that the first to the market was the tea tree oil, the Clearadex. Probably if you go with more efficacy, quicker acting, that you would use the XDEMVY, this Lotilaner ophthalmic solution, and then maybe you'd maintenance it with the tea tree oil that's out there. So one is kind of, if you want to say allopathic, that would be your XDEMVY, and then if you want to go more naturopathic, right, using a tea tree oil, that would be your Clearadex, and I think there's a Clearadex Light that comes with it.
A couple questions that came in, if you don't mind.
Yeah, go ahead.
One question is, why not use an antibiotic steroid combo ointment?
Yeah, that's a great question that's out there. This is not a bacterial infection. I think the steroid ointment that you would use, if you use Tobradex or Maxitrol, they both have dexamethasone, it'll probably fix the itching part, make it soothe, but you wouldn't really address the Demodex part, because it's not a bacteria, it's more of a mite. So it's that crime fit the punishment. It's a great question that's out there, but it's not a bacterial infection. So that the other, the tobramycin or the what's in Maxtrol, neomycin and polymyxin B that would address that. So we're actually going right after the mite, targeting its nervous system that's out there. So we would go with this medication. But probably, again, just to say it's more efficacious.
Really, what happens is you might clean away their feces, which is really what you're doing. You're cleaning away the feces, but the organism is buried underneath there, as Greg shows here, and those drops and ointments probably aren't going to be getting in there. But Christina asked, why not use hypochlorous acid spray with eyelid cleanser?
Yeah, I think all of these are great comments. Hypochlorous acid, where does it come from? It comes from a white blood cell. That's why when we get sick, our white blood cell goes up. Our body forms things like hydrogen peroxide. And one of the things that come out of a white blood cell is hypochlorous acid. It's part of that kind of defense mechanism. Again, probably going by efficacy, targeting, going after the mite itself. I'm not sure if hypochlorous acid has, they probably all work. Hey, I see an improvement, but probably if you look at the efficacy of all these different treatments that are being mentioned, you're definitely going to have a higher efficacy by doing it. Obviously, the company hasn't done any head-to-head studies, right? So if I was doing a dinner program, we have to be compliant and stay, not to get them in trouble. We'd have to say, look, there's no head-to-head studies. Well, as of right now, there aren't any head-to-head studies, but then kind of using, kind of the science that Joe and I know here of, okay, hypochlorous acid, it's more of a white blood cell, probably going to work, but probably be more efficacious to use this medication.
Now, Greg, are you going to talk about the coverage and the cost, or do you want to address that now? Because that came up as a question a moment ago.
Yeah, I probably should get more, versed on it. I know that I have a nice little pamphlet at my office. It's coming to me right now. Is that they started off with the company that was out in Utah, and so did Bausch and Lomb at the time. They were getting inundated, and now I know to use a more of a specialty pharmacy in Monroeville. It might be CVS. It might be it's one of the specialty pharmacies. I have it all written down. Just talk to your rep that's in the area. Look for your Tarsus rep. Look for your ex-Demv rep. They'll come in, they'll kind of coach you. But right now, what I do is I live in Altoona, Pennsylvania. Next to Pittsburgh is Monroeville. My local rep came in and said, just prescribe to this local pharmacy. I prescribe it to them, and then they start all the prior authorizations that are out there. Pretty good coverage, as always, when it's in the commercial side. I think they're helping to pay for it and all that fun stuff. You might have to fill out a prior auth, but you have to use the proper coding, and they have it all written down. It's like B88, B11, some like mite infection or however it's listed, and then unspecified blepharitis. And I have it all written down. I actually put that into the pharmacist comments whenever I prescribe it. So again, the short of it is work with your local rep, your Tarsus rep, but you would then just again prescribe it, and then I make a few notes about the infection and then the unspecified. All right, let me come through here and see if there's any other questions. Why not use hypochlorous? We talked about that. I tell people it's a microorganism and it's part of the natural flora. Exactly. That's why we don't want to say eliminate it, right? But some people, they get out of hand. So, I've been doing a lot, as Joe knows, of, if you want to talk about holistic, we have our gut microbiome, right? We always hear about that. And the gut microbiome leads to leaky gut, which is nothing more than leaky poop going through there. But we have to have the good bacteria in our body, right? And whatever you read, we have 4 times, 6 times, 10 times more microorganisms living on our body than we have human cells. So we're living symbiotically together here. But my point of that is I think we have, our own, we have a gut flora. We have our own ocular microflora, right? We have the Staph aureus, the Staph epidermidis. We got a few mites hanging around. And so again, these are part of the normal flora. So when I hear speakers say, you know, we're going to eliminate them, well, we're not really eliminating them. They're just out of hand. There's probably maybe something dietary going on. Maybe that's why they have it, or health-wise going on. But we're just trying to bring them back to a normal amount. And you can see here that they're living down in the shaft. They're feeding off the oil. You know, these are some of the slides that I was able to get from the medical science liaison of Tarsus that they're able to share, and I'm able to share with the audience. And, you know, again, it's inflammation. 69% of the cases are due to Demodex infestation, leading to Demodex blepharitis. Two types of the bugs that are out here. Uh, you know, I don't think it really matters much to know which bug it is going down. We just know that they're overgrowth, and we want to kind of bring them back to normal. And so when you have this, you know, the mechanism of disease, you know, the mechanical side of it is happening. The lash uh, distension occurs. You got the deposits. And then it starts allowing the bacteria to kind of get out of hand because you're throwing off the homeostasis. You kind of have the chemical, right? The meibomian gland, you know, we hear meibomian gland dysfunction. We're getting down there. It's disrupting the oils coming out because it's feeding off of these the epithelial cells here that are producing the oils here. So the inflammation in the conjunctival tissue. And we can see here that there's eyelash disorders, meibomian gland dysfunctions we just talked about. We could see the inflammation that occurs. Maybe we can get a cornea manifestation. Looks like maybe like a flectenule here is occurring and infiltrates. And then the conjunctival redness, you know, and there's probably degrees that are out there, right? We could probably stage this condition, you know, it's, you know, asymptomatic, you know, stage 0, or maybe that's stage 1. You know, I always think that we make our grading scales too small, 1, 2, 3, 4. Maybe it should be a 10. And, you know, if you start getting corneal infiltrations, that's kind of more of the, you know, getting down to 8, 9, and 10 side of it, and, you know, the asymptomatic patient. So, you know, we want to 80% of our patients report, you know, negative impact on the quality of life. And we heard Michael there. He didn't really realize that his eyes, I mean, he did realize his eyes were itchy. And this is what Joe was going on, you know, dry eyes and itchy eyes. If you think you're going to treat this with like Patanol or maybe some, you know, Ivizia or some type of tear, again, you always hear us say the crime must fit the punishment. So now that we have a good treatment out, you know, it was always, you know, I'd see it and we would do the Clearadex, and it might take 3 or 4 months of Clearadex twice a day and so on and so forth. But man, we have a really good medication here that's really efficacious that's out there. So just kind of curious if you want to put in the chat box, has anyone else out there used it, had success? Again, here we are again with the GABA-gated chloride channels. I said calcium earlier. It's the GABA-gated chloride channels, which is only found in the mites, not really found on the human body, which gives it a really good safety profile. And again, whenever I was in San Diego a couple of years at the academy, I said, so let me just get this straight. It kind of paralyzes them so they can't move. They can't have sex and replicate, and they can't eat. So then they just die, right? And the scientists said, I don't know why you always take these kind of complex ideas and boil them down like that, but that's true. It just kind of paralyzes them. They can't eat, they can't mate, and so then they just kind of die off there, can't produce any more eggs, and so on and so forth. But it's, again, working on that GABA-gated chloride channel. And again, humans don't have it. And there it is again, twice a day for 6 weeks. And this is an older slide. This was called TP03 before it was approved. Again, it's by Tarsus, and now it's called XDEMVY that's out there. So again, TP03, XDEMVY, it's now approved. Multi-dose bottle, it is preserved. Again, for the treatment of Demodex blepharitis, it paralyzes, as we talked about, with that GABA chloride gated channel. Collarettes were identified in the standard exam. It was used twice a day for 6 weeks. Again, I would tell you to use it until the bottle is empty. And they were looking for, you know, the collarette cure, the mite eradication, looking for redness. And obviously it came to market. It passed all those phase 3 trials out there. And again, very, very well and safely tolerated. I do have patients now that are, you know, beyond 6 weeks, and I really haven't seen many issues with the medication that's out there. So, Joe, before I move on, do you have any comments or is there anything else that rolled in here? I
Well,
got a
something
direct message.
that roll in is it safe for kids and pregnant women?
Yeah, I'd have to pull up the package insert. I would say the package, if someone wants to Google it, the package, just Google package insert of this medication. It's probably going to say 18 years or older for the fact that they probably didn't do it in pediatrics, and that's what they always do. They always put 18 years or older, but I certainly wouldn't have any problems using it in someone younger. Again, it's this GABA-gated chloride channel that we don't, humans don't have. So I certainly wouldn't have a problem using it in children. I'm not sure what it would say about pregnancy. I probably, anytime I have, if they're not red and irritated, that grade, 8 or 9, I'd probably hold off on a pregnant patient just for the fact that, if they have red, irritated eye or just itchy eyes or on that kind of asymptomatic range, say, hey, let's never ever give you a chemical that we'd ever be scratching our head about and come back afterwards. Probably the package insert is going to say wasn't studied in pregnant women and we don't have any side effects from it because, they don't do studies in pregnant patients. What happens is the patient doesn't, how they get the data is the patient doesn't know they're pregnant and they've been using the medication for a while. So I'm not even sure what 6 weeks would show with the 6-week usage. So I would just avoid in someone that's pregnant and just say, hey, look, when you have your baby, let's have you back, or maybe when you're done breastfeeding and all that fun stuff. So, and again, children, it's probably going to say 18 years or older. All right. In regards
Greg,
to the rest
I
of,
don't think I've ever seen this in children. I don't think I've ever seen Demodex. I have seen psoriasis, pediculosis, but I don't think I've ever seen this. But then again, I don't see many kids at this point either.
yes, yeah, I was just reading a question here. So yeah, I'm not sure if I have, or I don't see that many kids is the issue. Is I usually see the kids that are, I'm taking care of their grandparents and then, will you see my grandson or granddaughter? Sure,
Mm-hmm.
no problem. All right. I got a direct message here. It says, in regards, yes, it was Blink RX, the specialty pharmacy. Blink RX, CVS, Walgreens are two inundated. Also helps to use XDEMVY in conjunction with Avenova, Claridex, long-term maintenance. Yeah, I mean, all these are great. Probably if I was going to go treat Demodex, I'd go Avenova because tea tree oil, again, has a higher efficacy. But, any of these hypochlorous acids, that's what Avenova is. Claridex is tea tree oil. Anything you feel comfortable with, it's to me, reset them back and try and maintain some to keep them quiet from coming back. And check them, 6, 8 months, 9 months down the road. All great questions. Use like regular eye drops, especially applicator, or use on closed lids. Yeah, that's a great question, Todd. It's, as you can see here in the picture, it's a bottle. So just drop it into the eye. I tell the patient close it maybe for a little bit to maybe get it there, but certainly that's not Tarsus's, in their package insert. It's just drop it into the eye, twice a day, and you do it for 6 weeks. So, I've had some patients say, look, if you get too much in there, we know the eye only holds 11 microliters. These drops are usually 30 to 60. So if they close their eye, that little extra runs out. If I tell them if they want to rub it into where the base of the eyelash is, I'm not sure if that increases the efficacy or not and gets the medicine wherever, but it is just a regular eye drop twice a day. Good question. Yeah, into the eye, Stephen. The drop goes into the eye, just a regular eye drop. It's not like an ointment. And it's strong enough at that 0.25% to get to those GABA chloride channels. All right. Great questions. I wanted to go a little slow here. That's why we wanted to get the questions in here tonight. Didn't want to be like drinking out of a fire hose. This is kind of new. I like it. I think it's working well. Again, I have no financial interest in it, but it kind of met an unmet need. Joe, do you have any comments on it?
No, you said it right there. It meets an unmet need. We're trying to get to a more normal homeostasis. You need to treat this if it is overwhelming in any case of ocular surface disease. I think that pretty much covers it, Greg.
Perfect. All right, let's do this polling question right here. I saw it come up. Have you ever had to avert an eyelid on a patient with alopecia? Yes? No? You can't do it. There's no lashes. I've certainly had patients with alopecia come in, and I've always wondered what I would do if I had to avert the eyelid, and I just had one. I'm 28 years into practice, and guy came in and working on something and so on and so forth, and had to flip his eyelid. So here we go, share the results. All right, so we've had 26 people that were able to avert an eyelid. So that's great. And we have 60 people that, so I'll stop sharing. And so here's my patient, and I had my technician. This is my second run with it. Here's my patient. You can see alopecia. And what I was using to flip the eyelid here is, this is from Tear Care. We were playing around with this at the office, and they come with these forceps. So it was, these are to squeeze the meibomian gland. So I was able to numb his eye and get it up underneath the eyelid there and kind of pull down as if you'd pull down if there's eyelashes. And when I got that release of, I guess, of that tarsal plate, then I was able to hit with a cotton tip applicator, as you'll see here. So I'll just play the video. First time in 28 years I've had to flip an eyelid on someone with alopecia. So let's see if we can. I came up with this technique a little bit ago, and let's get the microscope back. We're going to take these forceps here. I'm going to go up under his eyelid. There you go. You see that tarsal plate release there? Cotton tip applicator ready. And there we are. How to flip a person with alopecia and no eyelashes to grab. But this is the second time around. I've already looked. There was no foreign body in there, but if there was, I would just wipe it off. I had to get creative. First time in 28 years. We got another video here. All right, what did you tell me there at the end?
I hope it helps somebody in the future.
Yep, there you go. So thank you, and thanks for letting me do that again.
You're welcome.
So, all right. So I just said to him, I said, before that, I said, do you mind if I record that? And he said no, and he knows that I teach and so on and so forth. Joe and I teach and like to do education. So he just said, I hope I can help someone in the future. So hopefully out there, I mean, that's not a big case, but it was the first time in 28 years I've had to flip someone with alopecia. And I just had these forceps that, again, they're squeezing my meibomian gland after a Tear Care treatment. And I just used that to kind of flip it. So first time in. All right. So here's the next case that's going to happen is it's a 92-year-old woman. It's one day post-op. Tonight it's just trying to make a bunch of pearls and try to help you out here with some different cases. This is a 92-year-old woman. She comes in one day for cataract surgery. And when we see her cornea, you look at it and it's got all this edema in it. And if all you have done cataract surgery, post-op, you're like, oh, the pressure's probably going to be up, and now we have to deal with that. But when I did the pressures, we have 11.2. I use the ocular response analyzer. That's where that comes from. And 14.3. This is at 10:30. And we have this edema. And yeah, I worked in an ODMD place for years, and we go into to cataract surgery. And if you look here, if I have it animated, the edema is kind of centrally located. We're actually pretty clear out here. And usually when you get those pressure spikes, they're probably up to 50 or 60 during the night, or 40, 30 to 40. And that cornea swells. Usually what happens is the whole cornea is swollen. And if you look over here in this picture and where I have it outlined here, I'll take it away. And then you can kind of see now the outline. It's right there's where it stops, and then it becomes clear. And what happens is when they're doing the, cataract surgery, the eye is dilated, and that phaco goes a little bit towards the cornea, and they're basically phacoing a little bit in the anterior chamber, and that energy kind of stuns the endothelial cells, even though they have viscoelastic in there. So I don't know, in our practice, and we just call that kind of phaco, edema, phacocornea edema, that's out there. And as opposed to pressure spike. So if you ever had that and you're like, maybe to tell the difference between the two, if the whole cornea is swollen, it was probably an increased IOP. If it's more localized, you can see here I was trying to catch some of the folds. It's just kind of localized and clear to the edges. It's probably just the lens came forward and they just phacoed it in the anterior chamber, and it kind of stunned those endothelial cells. So, all right. What's the name of the forceps? I'm not sure. The name of the forceps. We're going back to this here. It's with the tear care. Maybe if you reach out to the tear care reps, maybe you could get this. But again, when you do a tear care, which is you put the heating devices on the meibomian gland and you heat them up, they come with and the FDA made them put a fresh set in every time that's out there. I think to bring it to market, at least that's what I heard. So you get a fresh set of these. So we got a bunch of them laying around, and obviously we kept them. I guess you're supposed to toss them or use them on the same patient, but we autoclaved them, and we just kept them around. So I'm not sure if it has a name that's out there. Joe, are you familiar with any name to the meibomian gland squeezer for the tear care?
No, but I was also just thinking that a Chalazion clamp would work pretty well in a situation like this too.
Yeah, yeah. If you have access, if you're in an ODMD practice, or if you have a state that you're allowed to do Chalazion, that's a great idea. All right. See several kids with how do you even say that? Something mania, and I have grabbed the edge of the
Trichotillomania.
trichotillomania. Thanks, Joe.
Yeah, apparently my new cat has that.
What is it? Help me out. You guys can teach me tonight.
Trichotillomania is I guess you can say, psychological obsession with pulling your lashes and pulling your hair out.
Oh, I got you. All right, there you go.
Kind
Well, thanks,
of
Tanya,
play.
for educating me and Joe. So, good.
Just it's like play, just a fascination or an obsession with hair and lashes, sometimes to the point where you're pulling them out.
All right, so getting the questions now rolling in on this. How long does it take to clear? 2 days probably at most. When I see them back for their 1 week follow-up, because I'm really not going to see them back any sooner. Some surgeons, they do dropless. I have surgeons in the area do dropless. The surgeon that comes into my practice, he'll usually do an injection around the eye, but still use one a day, Pred, Gaddy, and an NSAID, Brenfenac. What's the
Bromfenac?
what is it?
Bromfenac.
Yeah, that's it. Thank you. And so if they have that, I might have them say, look, you got some swelling in here, use that two or three times a day for the next 2 or 3 days, and then drop it back down to 1. And usually when I see them back at their 1 week, it's the swelling is gone. It's just more FYI, kind of just why isn't the pressure up and why is it up sometimes? It's just that you can see it's just very localized. Michael Tran puts in here, my OMD calls it a phaco burn. Phaco, not phase. Maybe did I say phase earlier? I'm sorry if I said phaco or phase. Phaco. And the width of the tear care is also great for holding and placing dried amniotic membrane. So that's another use of it. So there you go. Putting a dry amniotic membrane on the cornea, you could use that tear care forceps.
Just before you move on, Greg, I just want to just share a public service announcement for people. Whenever you have a patient come in with unilateral or bilateral profound corneal edema and folds in Descemet's membrane, now most people are not experiencing it right now, but we can still see it down here. Ask if they are lepidopterists or people that deal in the garden, because milkweed toxicity. If the milkweed sap gets into the eye, it'll cause profound corneal edema. It'll cause profound folds and Descemet's membrane because it shuts down the sodium potassium pump, and it is a cardioglycoside. I just want to share that with you because I probably see 1 or 2 cases a month. And if you're not aware of it, it can be somewhat disconcerting. Whenever I see it, I just ask the history. Invariably, it's there. Very simple. It'll go away, but steroids do help. Just a public service announcement. I think it's one of the true existential crises we have.
So here's a video, I guess, here of the edema. I'm just trying to get maybe just a better shot for you there again. You can see how it's just kind of localized to that center part. It's not out here in the periphery. And it just thought it was just kind of cool. And I always point these things out just for the fact that it, we get these unknowns come in. It's just nice to have a bunch of knowns to help solve that unknown that's out there. And Joe, you and I have not practiced this webinar.
Oh,
I knew you would.
I'm sorry. I looked ahead. I thought I didn't think you were doing it.
So here you go.
Oh, I'm sorry, Greg.
No. It's just I thought that you would talk about it. I thought it'd be a cool place because it looks similar, and you're the one that taught me about it. So here are your pictures from one of your slides showing this edema, and you're asking. You said that you learned to ask, at least in Sarasota, Florida, to ask if they have a butterfly garden, and this is the milkweed, which is toxic, right? So this would be more of a toxic keratitis.
But the epithelium is largely intact, and that's what makes it confusing. What makes people think it might be a herpetic, but it truly isn't. So you can the word is lepidopterist. These are people who study butterflies, or when I treat them, I consider myself a lepidoptometrist.
There you go. We don't have those many issues up here in Pennsylvania, so. All right. So we get all caught up, Joe. Someone asked about, and I see you put it in there, Pred Forte 4 times a day. Great. Milkweed keratitis cause corneal edema. That's the main primary folds and gardens. All right. So 25-year-old man with a painful right eye. I was welding at work. This happens a lot in my area, right? So I believe I have welder's flash, watering, sensitive to light, constantly pains. And you can see here, a lot of the times it's maybe the person walking by. Sometimes it's hard to strike. They've gotten these nice helmets now that they're clear. And then when you strike it, they instantaneously get dark before they burn the eye. But a lot of times what happens is they can't see, the shield's too dark. They peek around with one eye, and then boom, they get this intense sunburn is basically what it is. It's ultraviolet light that just, in a sense, just kind of scorches the eye here, and it just hurts. And they heal up pretty quick. This is a case, that again here, this is before, and this would be after here. So, do you have any concerns here with treatment? A lot of times people will say, oh, look at all that cornea staining. Let's not, use an antibiotic steroid. To me, you just basically radiated the front of the eye with ultraviolet. Yes, there's risk involved, but most of the times I treat these patients just with a doctor in a bottle, Tobradex, Maxitrol, antibiotic to help cover some of this. What's that, Joe?
Oh yeah, I lean toward Maxitrol just for cost and availability.
Yeah. And it's, it used to be a couple bucks. Now I think it's creeped up to 12 or 15, but it's, it's widely available. Neomycin, polymyxin B, get the generic form of it, and you can heal these eyes up here pretty quickly. The welders usually know about it, and sometimes they have a bottle of antibiotic drops at their show or at their shops. So 30-year-old. So if there's any questions or concerns about the welder's flash, or if you have any tips that you've treated out there, again, this is synchronous live, and that's what this is supposed to be. And here's a 30-year-old welder's flash. I've had welder's flash in the past, and it's this one's lasted a little bit longer. He's used multiple tears, drops, he's had buddies look at it at the coworker, has some numbing drops, it makes it feel better, but when it wears off, the eye still hurts. Coworkers are using magnifying glasses at work to take a look. He ran a magnet over his eye, and mom just says, "Hey, 30-year-old, why don't you just go to the eye doctor?" And so he does, and this is why he keeps getting red. Is right here. His mama knows best. Go to the eye doctor, get it checked out, and you can see he's all red and inflamed. And we're just magging up here, and he's got a nice little foreign body going on in the eye, and there's the foreign body. Do you ever use it says TLC, but probably a bandage contact lens, BLC? On the welder's flashes, typically not, because they heal so fast. Wouldn't be a bad idea to use it to get some comfort. Usually Maxitrol, one of my other tricks I should put into the slide would be Tylenol and ibuprofen. I usually tell them to take 2 Tylenol, which is 500 milligrams, and I tell them to take 4 ibuprofen because of the inflammation. 4 ibuprofen is equivalent to 800, right? Over the counter in the United States is 200 milligrams times 4 is 800. That's prescription strength Tylenol. And I tell them, look, it sounds like a lot of pills. I'm not trying to kill you. Your liver's okay. Your kidneys are okay. Ibuprofen's through the kidney. Tylenol's through the liver. You're only going to need it for today and tomorrow. Take 4 and 2. I write it all down so they don't reverse the Tylenol and take 4 Tylenol. So 2 Tylenol, 500 milligrams, 1,000 milligrams, 800 milligrams of ibuprofen, all at the same time. Gets them some nice pain coverage. I could do that 2 or 3 times a day and be safe. The upper limit of this one would be the Tylenol at 3,000 milligrams a day. So I typically do not use a BCL. Joe, do you use BCL?
I do, Greg. I use it a lot. Any significant keratitis, of course, any corneal wounds, because this is actually what separates us from the urgent care walk-in. Somebody comes in with ocular trauma, they have a corneal abrasion, they'll get an antibiotic, but that just kills bugs. It doesn't make them feel better, or God help us, they'll get tetracaine to use liberally. That doesn't help them either. It relieves their pain. But what you said with the analgesia, over-the-counter analgesics, great. Bandage contact lens, it's what separates us from the doc in the box. And the day that they start learning how to use a bandage contact lens, our referrals are going to come down.
There you go.
But that's what separates us.
Maxitrol, BID or QID. Typically QID. I'm not sure which case we're talking about. If we're talking about the cornea swelling that we had earlier with the milkweed, I'd say QID. If this patient came in with the burn to their eye, I would probably tell them to use it every 2 or 3 hours, calm that eye down, and then QID for 2 or 3 days afterwards. If I don't put a bandage contact lens on them, I treat a ton of these. These guys don't want to come back. They don't want to pay the copay. All that fun stuff. I've treated enough of them. They heal. Now, obviously, he healed up here nicely. He came back in. I might have said, "Hey, can I have your picture? Come in. I won't charge you. I just want to grab a quick picture for I can teach with." But they do heal up pretty quickly. All right, 800 milligrams ibuprofen, Tylenol, and using a BCL helps. Yep, there you go. Thanks for the summary there, Audrey. And then here we were showing this patient. Here's the foreign body. We saw that. So do you feel comfortable taking out a foreign body? Yes, no. I refer to an OMD or I refer to an OD.
I think maybe a good answer might be it depends. My wife Lori just had one not that long ago. A younger person hammering a nail, shattered, hit him in the eye, and she called me in. It was hard to tell if it penetrated all the way through. And trying the OCT, because it's metal, it blocked the OCT, so we couldn't see if it was into the past Decimase. So, one of our corneal specialists was in surgery. She couldn't help. The other corneal surgeon was not available. He tells my wife, "Yeah, just pull it out." Well, she goes, it might be perforated. She goes, just glue it.
Mhm. Exactly.
They do have pretty good faith in us.
Yep, that's that's when you work with some MDs and DOs and that. Like I said, glue it. And a little fun fact, crazy glue is what that is when they're talking about gluing it. It was created for vascular disease back in the day. It worked, but then later it would break and patients would have very bad complications. Then it became crazy glue, and now we use it in different parts of medical crazy glue, if you want to call it that. It's used in cornea disease a lot, and so it's basically crazy glue, and it is gluing the cornea back together. So, all right, let me share the results. All right, we've got a lot of people here feeling comfortable, so we'll go quickly through this case, maybe pick out some pearls, those that feel comfortable. We have a couple that are no, and a couple that refer to the OMD. The only thing I would just ask there, the reason why I put that question is consider referring to an optometrist that's out there, right? I send my low vision and some of my sclerals and my binocular vision patients to all ODs. We're all licensed to do it. So as long as it's not penetrated, like Joe said, depends, consider referring to our colleagues. So let's see here. I think I probably did removal here. So here I am using, obviously I'll just pause it. The eye is numb. I'm not sure why it's dilated. I'm not sure if I dilated on purpose or if they just got a big pupil. But you can see I'm using a 27.5 gauge needle here. A lot of times around I'll have a cotton tip applicator that has some ointment on it so that if it does fall off, I can just touch it. I don't have to worry about the patient moving their eye and doing paracentesis on them. So I'm just going in with a 27 gauge needle here and just see if I can get it to lift off. We're not sure which video I used here. So looks like I can't get it. Let's get rid of it. Let's be worried about a paracentesis here. So let's just touch it and lift it right off. And then over here, you can see I'm just going to use this one here. He had two, a little small one right there. Clean that right up. And that one's gone. Okay. So let's see here, where am I? So, after the removal, what do we do here? I probably algae brushed that out. I don't have the video of it. Maybe it got deleted out. Use an algae brush. And then, here it goes. You can use a bandage contact lens, Maxitrol on these patients. I don't cycloplegic these patients. We had this big discussion in Scottsdale. If you read the books, it will say the cycloplegic, but I don't think these patients, they're not in any big risk of iritis here, not really having ciliary spasm. I typically do not cycloplegic. I'd put a bandage contact lens on, maybe some Maxitrol on this patient, and then see them back in a few days if there's a bandage contact lens. Again, and I live in a pretty rural area. Sometimes these guys are back on the road driving, gone. So, just have to see them back maybe in a week or just tell them to give us a call that's out there. Joe, do you have any tips or pearls? A lot of people felt pretty comfortable on this, but do you have any pearls? I don't see anything rolling in. You could still use the Tylenol. And
No, my pearls. If I end up giving a fairly substantial abrasion, I might put a bandage contact lens on. I agree. Generally, we don't. Especially something this small. Lubricant and the antibiotic steroid would be great, but it's not like you have a 20% corneal abrasion where they need help healing. Then that's different. But a little thing like this, I agree. It may if it's more extensive and I end up having to take out some epithelium, I might do it, but for the most part, you don't. I agree with you entirely, Greg.
Stephen asked, do you prescribe antibiotics? Usually just topical, Stephen. Again, Tobradex or Maxitrol, typically Maxitrol because it's got two in there, the neomycin and the polymyxin B. So I just go topical. I don't do anything oral on these patients. And Audrey asked about, Maxitrol, which would be generic, 3 times a day. Yeah, that's probably sufficient, depending again on, like Joe mentioned, if it's pretty traumatic, I might tell them to use it for 5 days. A lot of times I'm not, they don't follow up. So I just try to keep it as simple as possible for them.
Greg, there's a question about bringing them back for residual rust. Do you let the rust stay? Do you let it move superficial? How do you handle that?
Yeah, that's a great question that's out there. So, here's, let's say the foreign body is right here on the presentation. It's pretty centrally located. Let's put the foreign body right here, centrally located. If it's centrally located and it's been there for a little time, I will take the foreign body out, maybe buzz it with the algae brush, but then maybe sit on it for 2 or 3 days to move it forward, and then it will come right on out. We're being cautious with the patient. The patient needs to know we're trying to prevent a scar, prevent any halos around there. When we start getting out to the periphery, I start getting a little bit more aggressive in the treatment. So there's certainly nothing wrong with sitting on it. You're going to have to just reabrade them, and it's just going to make it a little bit longer. But always being conservative is a nice approach. Joe, do you have any comments on that?
Yeah, I'm gonna go back to Stephen's comments about, do you prescribe antibiotics? Stephen, the answer is yes, absolutely. I'll give you a reason why. When we were at university, my wife worked with a colleague who almost boasted that he never gives antibiotics for these things. And then she saw one of his follow-ups with a corneal abscess, and that then ended up perforating. So the answer is yes, you do prescribe an antibiotic. And the person afterwards, I guess, learned his lesson somewhat. Would go around, saying he got burned on. He never did it before, but he got burned on one case. And my thought is, well, you didn't get burned as bad as the patient got burned.
Yeah. Yeah, you definitely want to cover it with something. I just don't go as strong as orals, but definitely a topical for sure.
Yeah, no reason not to.
Yeah, great point out, Joe. Yeah, great point out. So looks like I have a video here. Is there any other questions there, Joe, that have rolled in? It says, do you ever have a patient come back? How do you clean the algae brush? Yeah, I see that one came in. We have, I just wanted to say Claridex, Sidex. What's the, what do we have in the container? And we pour it in there, let it soak and overnight. Geez, what do we use in the office, Joe? I know you have it in probably your offices.
I'm going the same blank that you are. We have a small autoclave we use.
Yeah, there are, autoclave would be a great way to do it. That definitely gets you there. And this is driving me crazy. Someone out there who knows it, put it in the chat box for me. It's the liquid that you pour in and let it soak. You reach in with some forceps and rinse it off with some alcohol. I don't order it. That's why it can slip in my mind. So you can go both ways. Alcohol is probably good enough too. Be careful with an algae brush and an alcohol. I've done that a couple times, and then all of a sudden you get the little fibers wrapped around it, and then you're trying to pick Cleardex or Sidex. Thank you. Thanks, Kim. There's a friend. I think she was a year behind me in school. Kim, thank you for saving me. Sidex is what it is. So it's an fungal. It's an antimicrobial. It's cidal. That's why it's Sidex. So it's bacterial cidal, fungal cidal, all the cidals that are out there. And you just soak it in there, just read the bottle, how long it needs to be in there, 20 minutes, 5 minutes, pull it out and rinse it. So that's a great way to clean the tip of an algae brush. Thanks for the question, Audrey. All right. So 59-year-old man, foreign body sensation. We can see what happened here. Now, what I like to point out here is I'm going to be more aggressive, but I'm also going to be around where there's a lot of inflammation. They're going to feel this out here by the limbus and the conjunctiva. There's a lot of the corneal roots. If you look at how the cornea is innervated, a lot of times I like to point out is as long as the cornea is intact and there's not a laceration to the cornea, I do keep lidocaine in the office so that I can use it to really get a deep anesthesia. The tetracaines, the proparacaines, the binoxynates, they're all an ester base. So if you have a red eye, which you can see right here, it's red. there's a lot of plasma cholinesterase. It's hard to get a deep anesthesia. So there's a lot of times I'll just draw up a couple drops of lidocaine. Again, be careful because lidocaine is toxic to the endothelial cells. You can kill the endothelial cells if it gets into the anterior chamber. So you just want to drop it on. You get a really nice deep anesthesia, a lot deeper than proparacaine, and then you could take out the rest ring. So it's probably what I did on this case. I think this is a case of just removing it. The patient came in. Well, I guess I'm just showing you the rest ring here. Thought I had the video of it. I apologize. So, started 8 days ago. They prescribed some gentamicin. There's Joe talking about the doctor in the box there, foreign body sensation and redness. Oh, there we go. And there is a foreign body there. So we're going to lift that right off. You can see, oh, and it's just something that might not even be metallic.
And this is the part I hate. Once you easily dislodge it, then you got to fish it out.
Mm-hmm. Yeah, that's why I keep that cotton tip applicator with, some type of thicker gelish type of ointment on it. We used to keep Celluvisc, but that's hard to get. So something a little gooey that we can just touch it. What's the worst case scenario if they don't come back to get the rest ring out? Well, they'll come back because they usually will get inflamed. They'll have a little bit of probably an infiltrative type of keratitis. And I guess, what's the worst case scenario? It turns infectious and then perforation, but haven't really seen that. I've seen them where they didn't come back, and then 2 weeks later, their eyes all red and inflamed because the body's reacting to the kind of the dead tissue that's there. But Joe, any thoughts on that?
Yeah, Greg. I remember a case where I saw a person who had a pretty significant rust ring. There was no "quote unquote" foreign body injury that we know of, but he had a pretty good rust ring. And he was asymptomatic, and I suggested he let me take it out, and he declined. All right. Then 3 days later, he was back in intense pain, barely able to open his eyes, and it made it a lot harder. But now, it certainly had to come out. So obviously, you got something in there. The foreign body rusted, and it moved forward and started touching the nerves, and that's when it became more symptomatic.
Great. Here's a 79-year-old man with a foreign body sensation, history of cataract surgery, and he had a DSEC procedure. And you can see right here, we have a broken suture here that's going on. And what you'll do is you'll be able to see here, I'm able to, eventually, I'll probably think I'll get it better. You can see the mucus that's building up on it. Putting some sodium fluorescein stain. Loves that kind of mucus type of, it's all stained up. Got a broken suture here. The key that I want to point out with this is, we're just going to kind of grab this edge here and just kind of pull on it. And right there, you can kind of see that was easy to come out. It was probably in there for a little bit of oh, there's the suture. I broke it. Let's see if I go in and get this out. There we go. Thought that was a little easy. See the cornea is, I want to be careful with this. Oh, I must have taken it out but I pull that out there. What I want to point out here is you want to try and see which way the suture's going. So you can usually tell if you look at it, if you want to take this suture out, what you want to do is you want to cut it kind of in the center, and you can tell by the way the threads are going, the suture's going, and you want to kind of pull it out the same way. If the knot is on this side, obviously you don't want to go through where the graft and host is, but you kind of want to follow the way the surgeon put it into the cornea, so that it just kind of keeps coming out there. So let's see here. I switched up forceps here. The other ones were too sharp. You can see the eyes moving. You have to kind of, there you go, feel that little pop. And I didn't want to go through, I guess that's not a PKP, so the graft wouldn't be all the way through. So all I had was that little edge there. But what I want to show is that it takes a little bit of aggressiveness there. Watch this eye. You'll see it kind of deform. You kind of want to pull straight out. You don't want to kind of go to a different angle. I went with different forceps here because the other ones were too sharp and it was cutting it. So you can see here, it takes me a little time to kind of get a hold of it. But then whenever we get a hold of it, you'll see right there, see the eye moving, look at the force, boom, and then it popped. And you just kind of want to keep that steady force on there if you're taking it out. You don't want to kind of yank on it too hard. It's just a steady, aggressive kind of pulling on it. You'll see the eye move, but eventually it will come out to get a good grip on it. And Joe, you still with us, or all right, looks
Oh
like
yeah,
you might have.
I'm here.
Okay. Do you have any comments? I'm sure you've taken out the foreign
No,
bodies or stitches.
no, you're spot on there, Greg. It's actually helpful, or when you see this, because you know what the patient's problem is, you can address it pretty succinctly. But now, do you worry about, I mean, anything getting into the eye when you've done that?
I mean, I'm going to cover that obviously now with again another antibiotic. That is,
Good.
I'm going to cover that with a Maxitrol type of, it's a little bit inflamed, a little bit of redness. At times, I'll throw, a betadine in there, a little betadine drop. If I think like some of my foreign bodies that have been in there, or the guy's like, yeah, it was pretty nasty. I was working on a toilet or something. So at times, we have betadine in the office, 5%, drop a couple drops on there, just like as if they were in surgery. And then maybe afterwards, put a drop of betadine in and then cover it with Maxitrol. So, yep, cover that up. All right, here's a 53-year-old man, foreign body sensation. We don't have to put anything in the chat box here. He thinks he scratched his eye, feels better, tried some refresh eye drops. And what we're going to look at is this little guy right here. And you can just see how that sodium fluorescein has absorbed up into that kind of mucus area. And it's just nothing more than a filament here. So I got a direct message here. It says, any recommendations on removing foreign body in children?
Oh.
Here would be my
I-
recommendation would be, obviously we don't want to get as detailed with the adults that we do. Quick, lidocaine probably if you can get it in. And so that will really numb their eye. Obviously, again, if it's not a lacerated cornea, just make sure, because it kills the endothelial cells. Numb their eye up really, really well. Have everything ready. Have an assistant in the room. Hey, we're just going to use something that's going to tickle your eye. Take out the foreign body. Touch it with. The key would be just quickness. So I do have children that come in, and I think that would be probably my best is be quick, have everything prepared, and use lidocaine.
That's a tough one, Greg, and that's a good question. The answer all depends on the patient, and they're in pain, they're afraid. Dad or mom or both are going to be there helping. Wow, it's a pretty tough one. So I agree with you. The answer, it kind of depends. My wife had one of these in our practice, probably 8 or 9 years old. She said she was a champ, did a great job. Everything was great. They walked out to the front desk and she had a syncope and did a header. We're right there in her waiting room.
Oh, nice. Yeah.
So anything can happen.
Yeah, what you
Do you ever
can
use-
do is if you'd send it to like a surgeon, they would put a lid speculum in, and maybe, I'd hate to have a foreign body go after anesthesia, but I guess that would be the scenario if you had to do it. So
Yeah, for uncooperative patients, and this includes adults as well. My cooperation kit is speculum, Velcro straps, and bite pads.
there you go. Do you ever use Benadryl for those excessively anxious patients? I have not used Benadryl for those patients. Also recline the kids in a chair, use a BIO. Thanks, Jody. Great comments from experience here. Use the BIO so both hands are available and can't back away. There you go. Thanks for the input. This what makes it live and synchronous. Thanks everyone. So this is here is a filament. I'm just going to keep going until I see more things roll in here. This is a filament, and I think we showed the video here, and the patient was blinking. So these are, what do you use to remove it? I usually use a Wexel sponge to remove these. You can see it's stuck down pretty good to the eye. It's moving. This is why they have the foreign body sensation. They're irritated. You can see they're red and inflamed here. So now we'll just go to here. Here's the Wexel sponge. Sometimes I'll wet it and it expands out. It's like one of those magic sponges. Sometimes I use it dry. When it's more dry, it's a little bit more rigid, easy to pick this off right here. You can see that there's some swelling going on here, but you can see the big old filament, and the edge, the origin of it is down here. So we're just going to kind of go in and just kind of find it and wipe it off here.
And sometimes I'll use the forceps and actually pull it off. I describe it to patients. It's like a leech.
Yeah.
Yeah, you get the tail, but the mouth is still hanging on to you.
So Wexel sponge or spheres, you can use forceps, whichever way you can get it off. Here I am kind of showing you here it is dry. And if you do wet it, it expands out. That sometimes it can use it to kind of smooth things out on the cornea. So however you want to use that tool. Sometimes if I have a recurrent corneal erosion that comes in, I'll wet the Wexel sponge to kind of, maybe to take off most of it. And then if I have to clean up some edges, I'll wet this up. It's a lot softer. It's a little bit, easier on the cornea here. But we keep them in the office. Become sterilized. You can use it in the operating room, but so this is always nice if you think you have something that you want to use that's sterile, or by the time you use it's going to be semi-sterile in your exam room. All right, so 2 days later, how's this patient look? You can see what I have on here: a bandage contact lens. If you listen to other kind of speakers out there, you'll hear them say, you don't even have to take these off. Just throw the bandage contact lens on there and it goes away. If they're recurrent, you might want to use like an amniotic membrane. But this was the first time this happened to this patient. I'm not sure if they got a scratch here, and it created an unequal, and it created a ledge, and then the mucus built up. But I did take it off, and you can see here, because it had all that kind of unevenness where that epithelium was. And then I did put a bandage contact lens on the eye. And then 1 month later, you can see that they're all healed up and no more reoccurrence of the filament. So this was not like a rheumatological patient. They just had a big old filament build up there. Not sure why, if they scratched it and it built up, but we just treated a filamentary keratitis. A lot of times we see these in the rheumatological patients, and they do respond well to Regenerize types of drops, or vital tears, or bandage contact lenses, but this was just kind of a one-off filamentary keratitis that was out there. Any comments, Joe?
I agree with what you say. I like to pull it off, scrape it off. Steroid antibiotic combination usually works for me.
All right. Would there ever be a situation would you not want to remove an exposed suture? I would say if there's an infection going on, you might want to get it off to the cornea doc that day. If the wound is gapping or has a gape in it or opening up, but if everything's kind of just broken and intact, I would probably remove it in the office. But again, it comes down to your comfort level. Any thoughts here real quick, Joe, on never removing a suture that's exposed?
No, I mean, obviously, if you think it's going to lead to a leak, you don't want to do that. If there's infection, you don't want to do that. For the most part, if they're broken and causing a problem, it's got to come out, either you or the surgeon. And what you just demonstrated here on video was fantastic learning. I think we should do a kind of a public service announcement for people to understand you are indeed left-handed.
I am indeed left-handed, and I am ambidextrous with that right hand too, but I am left-handed. So Audrey asked, no antibiotic coverage with BCL? Probably 99.9% of the time there's going to be coverage with some type of antibiotic or antibiotic steroid if there's a BCL going in there. I'm not sure if I can think of anything off the top of my head where I wouldn't put a antibiotic. Well, one I'm thinking of right now would be if a patient came in with a leaky bleb. Their pressure is 0. And I'm just trying to cover that bleb and that Seidel sign. It's already leaking out. Probably put a bandage contact lens on. It may already be on antibiotic steroids from the surgery. But I can't. Anything, Joe, that you're thinking where you wouldn't cover it with a doctor in a bottle, Tobradex or Maxitrol?
Well, just as you're explaining, like the leaking bleb, actually something like a leaking bleb, you might want to use something that is a little quote unquote toxic, such as a tobramycin, because that can cause some inflammation and maybe actually help seal that leak.
Yeah. Yeah, that's a great pearl. And then, try to use a lot of aqueous suppressants to try and slow down that flow a little bit. What type of bandage contact lens you use? I have a whole bunch in my office that are the Alcon Focus Night and Day. Again, not saying any superiority over any other that's out there. I like it because it's approved for sleeping in. I keep the 8.4, 8.6s. I keep plus a quarter, minus a quarter in the room. All the rooms that I work out of, there's usually any given day 4 to 6 bandage contact lenses in there. And then again, yes, we use antibiotic steroid drops or antibiotic drops on most of the cases. Do I dilate? Not on these cases, these cornea cases, I don't. I mean, the filament, I wouldn't dilate. Again, I wouldn't cycloplege. Again, we had a great discussion in Scottsdale at our meeting there. I always resort back to like PRK patients. PRK, you take alcohol, you take the epithelium off, you smack them with an excimer laser, and the post-op treatment is not cycloplegia. That's a pretty clean but traumatic surgery. These patients that come in, if I'm not too traumatic on them, I won't cycloplegia them or dilate them. I guess unless I'm looking for a foreign body. In that case, if it was some type of looking in the back of the eye. But for therapeutic or comfort reasons, I typically don't dilate or use a cycloplegia.
I think, Greg, in that example that you just gave about PRK, they're being treated immediately right there. They're anesthetized, the cornea is scraped off, the excimer is applied, then a bandage contact lens is put on. It doesn't initiate the inflammatory response. The nerves are deadened, then they are protected. So that's why they don't need to use cycloplegia after PRK or a corneal scraping.
Right. All right. Looks like we're caught up on questions here. And so we're just going to fire this polling question off and people are rolling in. Do you insert punctal plugs? Yes, no. Refer to OMD or refer to an OD? All right. Looks like we got a pretty good amount of people weighed in. So we'll just share the results. Good. That's awesome. I was POA president in 2010 on the board for 6.5, 7 years. We fought to get these privileges. It's great to see a lot of people doing it. Not saying that if the 23 people that say no, not to say anything. If you don't feel comfortable, you don't do it. You can refer it, as we can see, to an ophthalmologist, or I see a few people referring that to an optometrist. I get a lot of these referred in. So again, just think out there. Joe, you do a lot of medical malpractice cases. I know you do that for Florida, the jurisprudence and so on and so forth. I don't know if I sent a punctal plug to an optometry friend of mine or an ophthalmology friend of mine and something went south. I don't know what would go south, an infection that closes off something. Is there any liability because you sent it to an optometrist versus an ophthalmologist?
The answer is no, because you're sending it to somebody who is licensed and skilled to do the procedure. These referrals, it's hard to say you made a bad referral, about the only thing legally anybody can pin on you is if you've knowingly referred a patient to a provider who is substandard or impaired. And that's really hard to prove that you knew that.
Yeah, so I think a lot of people out there think like, I sent it to an ophthalmologist. That if something goes bad, it kind of, the referral's the referral. So,
Yeah,
so
I mean, in many of these cases, the optometrist who made the referral gets sued as well. I'm not saying it is fair, but that's just kind of how it is.
yeah, if it's going to happen, they're just going to hit everyone who's
Mhm.
in touch with the patient. So.
Mhm.
So here's a patient, 75-year-old woman, in for a second opinion for severe dry eyes, history of rheumatoid arthritis and Sjogren's. I think that's the key right there. If there's not too many things in medicine that make me Pavlovian, but when I see Sjogren's and dry eye, it's probably going to need a plug just to preserve any little bit of tears that it's out there. The rheumatoid arthritis that might raise my eyebrow a little bit to the increased utilization of punctal plugs. But when I see Sjogren's, if they come in as with this past treatment of numerous over-the-counter artificial tears, everyone I could find they tried. They just tried because they all look different, and so they just tried them all. They've had Restasis, they've had Sequa, they've had Xiidra, they've been on Lotamax and Lotamax gel, Inveltis 1%, Isuva 0.25%. They got steroids. Last recommendation was Regenerize. So we decided just to chat with the patient about punctal plugs. The previous eye doctor said she heard at a lecture they would never work. Plugs cause inflammatory molecules to sit on the eye. We hear, drug before plug. And if you don't calm the inflammation down, then you're just going to build up all the inflammatory. And, it's why I hate being like binary or linear on these things. Is that, the patient has a severe dry eye. They probably need a lot more. They probably do need the plugs. They probably do need some steroids. In this case of a Sjogren's, that's out there. So the patient said they felt comfortable with everything. We decided to put a plug in here. So we can see here that we're going to dilate the puncta. And what we do is go down 2, and then we kind of rotate over. And you can see I'm rotating it, so we just get a nice dilation. I want it huge because I want to put the plug in here, and I don't want it to kind of fall out whenever I have it in there. So, the older the patient, the less elastin they have, so it can last a little while. I'll play that again, and we don't have to watch it to the very end. But again, we're going to put it into the puncta. We're going to start I'm kind of rotating my fingers there. I'm twisting it. It's kind of hard to see. And then now I've got the puncta dilated. Again, a little bit older of a patient, so it didn't take too long. So just pop, there it is. And then I'll push the little button. I usually pull out like I'm doing there just to make sure that I have it in. I'll play that again. I put it in, you kind of feel the pop. And then I'm not pushing the button. I'm pulling out. You're going to see that I have the right size is kind of what I'm doing, is to make sure that it's not going to fall out. And so you'll see me kind of pull out a little bit, and then I'll go back down in and I'll push the button, and then I'll just tap it down. So I'll just kind of show that again. So they're already dilated, go kind of straight in. You see the little pop, there it is. I'm going to pull out. I want to see if it's in there pretty good. Now I'm just going to go back down and push the button, and then tap it back down and to make it nice and to the ocular surface.
Greg, when you were doing the dilation on the first video, I wasn't sure if you're going to be using a temporary collagen plug or a permanent silicone plug, and you did the latter. What are your preferences?
Yeah, I mean, I used to do the temporary plugs, but then I didn't know if they slid down, they popped out, and it was kind of when I had a failure. I still would say to the patient, well, let's try a permanent since we know it's going to be in there. So I don't do that many temporaries unless maybe I'm trying to treat a cornea something. I don't really need a permanent, and I just want the antibiotics to build up.
Mhm.
But that was kind of my thoughts. But I don't think there's any right or wrong if someone does collagens and they're successful at it. I just kind of just jump right to the permanent plug. But do you have any comments?
No, I do silicone plugs myself because I think they're easier for me to handle.
Yeah.
I have used temporaries, and you can argue that, it's reasonable to put a collagen plug in every 4 to 6 months. I find them a little bit harder. Patients always wonder, why, when I bring them into the room, why bring three? Because they only have two eyes. And the reason is because I'm gonna drop one.
Exactly.
But interesting, that patient had so many things done to him. It's important for the audience when somebody comes in and they have all that stuff that has been done. The worst thing you can do is do the same thing and expect a different result. You've got to do something else. Plugs or serum tears or something.
Question came
Greg,
in. Oh, go ahead, Joe.
no, go ahead, please.
No, as I can say, there was someone that said any use of MIEBO yet, and you got
That's
the
what I was bringing up. Yeah.
correct spelling too, Miebo. Yes, I have. Probably my N of 10 or 15. I find it to be a pretty cool drop. In the fact that because it's so small, it's 11 microliters in size. It's 100% of the molecule itself. The perfluorohexyloctane is the ingredient. It's 100%, so there's no other inactive ingredients. With that, there's no pH, so it's a little tricky when the patient puts it in. They don't really feel it. It's replacing the lipid layer. It's helping with the evaporative disease, which it's claimed out there to be about 86% of the dry eye that's out there. 50 some of it is just pure evaporative, so at least you're treating that. And then there's some crossover with about 36% of evaporative disease and aqueous deficient. So you're getting to that 86 to 90% coverage of dry eye from evaporative. It does heal the cornea that's out there. I've heard some speakers say it's kind of a short-term treatment, long-term treatment. I'm too early in the game to make a really great assessment of that. Of my 10 or 15, they're on their second bottle, and it has healed that cornea staining that's out there. And it's a comfortable drop. I had a couple failures. A couple people didn't like it because they couldn't feel it. Felt that it blurred their eye, but so far it's been a success. But my N is only about 10 or 15. Any comments that you have with my Joe?
People like it. They feel that it helps them, certainly symptomatically, but again, coverage has been an issue for me.
Yeah, so you got to use the Blink RX. I think someone pointed in there. Thank you for who put that in there earlier. That's out in Utah.
Yeah,
and
you've got.
it's-
I think it's Boise, Idaho.
Oh yeah, you're
I
right.
could be.
Yep, you're right. It's Idaho. You're right.
Yeah, so Blink RX, they're going to do a prior authorization. They have coupons. You got to sacrifice a chicken, and maybe you'll get it done. Greg, what
There-
silicone plug do you like? I'm an Oasis person. I use Oasis myself.
Well, I'm going to go back to the old name and date myself because I know they were bought out, and my technician who's been around with the office since I've been around knows what I like. And it was the Parasol one, the silicone, and that's probably
Mhm.
Oasis that bought them out. But it's the Parasol design. That's what you saw in there. Um, I
At
see
what
a
point do you order
uh,
serum tears, Greg?
yeah. It's just like everything else. When you get more comfortable with it, you start moving it up. Serum tears used to be for the train wrecks and Sjogren's and rheumatoid arthritis, and now it's kind of like, geez, it's such a kind of an easy-ish type of place. Go in. I use Vital Tears. I guess you could use a hospital or whatever that's out there, but Vital Tears is. I've set up an account and they send the phlebotomist there. I think it costs maybe $20, but out here in the rural area, driving to one of their locations might be, $40 by the time they pay gas and maybe parking. So the phlebotomist goes to the house. I start off with 20%. Sometimes I go to 40% based on the disease. I have started with 50, usually don't start with 50. But when do I use it? In an inflammatory autoimmune patient, I just don't do it on a regular dry eye. Or someone comes in and they're a dry eye that they've used everything, and I'm not going to do plugs. They don't want to do plugs. That would be a good place for autologous eye drops. You hear them called ASED drops, autologous serum eye drops. Vital tears would be an easy way to do that, but there might be some hospitals out there that do it.
My threshold's pretty low. If tears are not working, they don't want to do plug. If they don't want to do plug, I think they need plugs. They don't want to do plugs. I'll do serum tears instead. If they have short-term benefit from a steroid, tells me it's kind of inflammatory, I'll do it. If there are signs you got staining, I'll do it. In our office, because we're a multi-office, multi-practitioner ODMD, we're using it so much we actually hired a physician assistant to do it in-house. And I think I was told she's doing 50 a week.
There you go. So you could use, if you use a lot, and get someone in your practice to do it. It was a big problem before. We used to do it at the local hospital in my area, but then with the pharmacists with the hoods and the mixing, and their insurance went skyrocketed, then it disappeared for a while. So I used to use the local hospital. Then I had to send them to Pittsburgh, and now Vital Tears is out. So there you go. Refrigeration of MIBO does help. It does fill on the eye, but it still doesn't have water in it. The MIBO doesn't have water, so it doesn't generate that energy that you do. The patients have told me it helps, but it's not like putting a teardrop in there and getting that energy building up, and when it hits the eye, it's a little bit different. I've played around with it. I have a bottle. I wanted to go through the process, and it's pretty unique drop that's out there. So. And Audrey, I did chat about the 20, there's 40 or 50. You can do 100% if you want. If you get that high, they're going to be drawing a heck of a lot of blood. So the higher the percentage, the more blood they're going to have to use to spin it out to get the amount of drops that you're looking for, that 3 or 6 months out there.
Yeah, I tend to do 40%.
Well, you're probably seeing a little bit more complicated, right? So Joe's probably seeing a little bit more complicated corneas that are coming in. 40 or 78-year-old woman here, foreign body sensation. What I'd like to point out is, look at these misdirected lashes and look at this missing area right here whenever we do that. So, they're being sent in, like it's recurrent. And I'm going to take them out here. You can see it's all covered in mucus. Just gonna set it right on my fingernail there. Sometimes I wrap my fingernail with a Kleenex and just kind of set it there.
Greg, watching this, the mucus coming out makes me think maybe I'll have spaghetti for dinner tomorrow night.
There you go. Do Alfredo. I didn't like the misdirection, and then I didn't like the area that it was missing here. And we've had, Joe probably sees a heck of a lot more basal cells than I do up in my area, but I didn't like the misdirection that we had going on there, and sent it for a biopsy, and it ended up being a basal cell there. One of the things I want to point out that Joe and I sit through a lot of CE, and one of the things a long time ago someone said is like, cancer eats away. It's got enzymes, so it typically erodes and eats away. And then if it's kind of an RNA virus or a DNA virus and it's a verruca, it doesn't have those enzymes that kind of eat away at the epidermis and dermis and go down, so it grows out. So typically when you see things that are growing out, you can kind of maybe exhale a little bit But when you start seeing things being eaten away, you know that those different types of cancers have enzymes to kind of eat away the tissue. So cancer, if you start seeing things, be careful. And that's what this I want to show you here. This patient is status post cataract extraction. A bunch of people doing post-ops on this lady. She's 3 months out, 5.5 months out. She's in for her post-op glasses. She wants to get her refraction. And whenever I kind of do her slit lamp exam, um, you know, we get down to this lower lid here. I didn't like what's right there. Okay, look, it's a notch. And so lashes are missing. We're eating down. We got an area right here that this doesn't look real well. I don't know if it's, you know, you go to and listen to all the lectures, the ABCs, you know, of you know, is it asymmetric, the pigmented borders, you know, the different diameter, so on and so forth. It's kind of hard at that location. So, you know, here's, you know, the just different pictures. I didn't like it. We sent it to the oculoplastics doc that I like to use. She had a punch biopsy and she was confirmed basal cell. I think this is her just sending me the video here of her eye after, yeah, after surgery. So this is what I think they did. Yeah, right there, a Mohs procedure. And you can see a Mohs procedure. What they do is they work alongside with um, a uh, a pathologist, and they keep taking the tissue, cut it off, give it to the pathologist. Nope, the edges aren't clear. Still got cancer, and they keep taking it away, keep cutting, but they're trying to minimize the amount, right? So if you want to get the whole cancer, you know, do you just take everything or trying to minimize? And you could see just that little area that started right here. She's got a conformer in, that's why that looks the way it does. Is that that's how much tissue they had to take away in order to just get that little area. So that's why we want to get them as quick as possible. I love my surgeon; he does a great job. And so here are the patients. You know, I told her come in. I just wanted to teach with the case. So she came in, and her eyelid is still stitched closed here. I believe if I pull up on it, it is. So we're just kind of lifting it. He did a great job he took skin from, I think from her back and from her butt and all over the place, and from inside her mouth to recreate the conjunctival sac there. Um, and so here she is kind of healing up. And again, it just all started with that little bit of a notch. Here's a month after reconstruction. We got the eye open, and let's get over there. Come on. Oh, we got an eyelash here. I'm not sure why I'm showing this, but let's pull that eyelash out. That looks pretty good right there. He did a pretty good job. You can see she got a tube in here for to help with where the location of the puncta was to help with tearing. He had to do a reconstruction of her lower puncta there because if you remember, that was all missing, and then he had to recreate that. So it's just amazing. And then 2 months later, I can't tell, is the tube in there? Looks like the tube is out. And here we are here with, yep, tubes out from the DCR-ish type of procedure. Didn't really have a DCR, but didn't really crack any bone, but it was in there to help with that tube. You can see we're healing up nice. And yeah, this is what she started off as. And then this is what she ended up looking like 8 months later. So this is the reminder. Come on, get down. So she's done well. Even her eyelashes have kind of grown back. in just that little area right there. Yeah, someone asked, it's Dr. Chu, Choo. He's out of Pittsburgh, but he comes to Murraysville, Pennsylvania, and he's about an hour from my office. He does a lot of aesthetics types of surgeries, but he also, as you can see, does an amazing job. Sent them lots of cases down. What do you see here? I think this is just kind of sticking in the cancer realm. Is, she came in for an exam, and I said, "Ma'am, how long has this been on?" Yeah, I just bumped it, and it just doesn't want to seem to heal. And so, I refer a lot of these out. This turned out to be basal cell, right? And they had a Mohs procedure, and I'm not sure if I have any before or afters, but I think this is kind of obvious when we're talking cancer, but in the heat of, electronic health records and you're examining the patient, maybe you're a little bit behind, don't forget to see, that these, if they're non-healing, to ask about these when you see the patient. This guy came in, he had this kind of red eye here, and as I'm kind of, I usually kind of, when I see these patients, I try to be, I guess, like a doctor of osteopathic instead of allopathic. Maybe look around, turn their head, see what's going on, and just happened to say, "What's going on here in your ear, buddy?" And this turned out to be some type of cancerous lesion, and he thanked me for saving it. Literally, I had to almost take off his whole ear and reconstruct his ear. That's out there. But he came in for this, whatever this little bump was, a little hordeolum or sty, and I don't know if I noticed it by putting his glasses on or not. This is a more recent one that came in. Again, we're talking cancer, but she fought me. So I'm like, "Ma'am, we're going to schedule the appointment for this. Look how it's eating down, right? Cancer eats down. It's got enzymes to eat the tissue." And she's like, "It's been there for 8 months." And I'm like, "Well, that's not really convincing me not to send you." So I literally and she called me up, she said, "Thank you." And they're going to do the Mohs procedure on that. So, my point is, we're eye doctors, but, sometimes we kind of just get focused to this area, but where you can help these patients out. And even her daughter called and said, "Oh my gosh, thank you. We've seen that, never thought about that. And at least we're getting treatment." So this one turned out this one's just really recent. I just got when I got back from Scottsdale, I saw the pathology report that was sent from the dermatologist. It's not always clear whether it's cancer. This one here came in, and so I put some Maxitrol on it, some steroids on it, and she cleared up. So this one here, I wasn't really sure. She's like, "Yeah, it's red, it's irritated, it does hurt a little bit." She got a couple of little inflammations on her skin. So I said, "Okay, let's just throw some steroid on it," and she cleared up. Cancer's not going to go away with a steroid. I could have used all the steroid on this. That's not going to heal. Maybe the redness would go away a little bit, but it's not going to close up and heal like this did here. So, I'll watch the area. If it comes back and starts becoming recurrent, then maybe we'll send it for a biopsy. But this one here, when it's not always clear. And if it's not always clear, refer. This one came in. They were treating it with doxycycline and a hordeolum that wouldn't clear up, and had some missing lashes and so on and so forth. I didn't know it was Merkel cell. I just said, "Listen, it's it just doesn't seem right. Let's go get you a biopsy here." And it turned out to be a Merkel cell carcinoma on this young lady. So where are we? Oh, we're done. We're at 8:52, aren't we? Look at that, Joe.
Here we are.
I was going to get ready to rock and roll. So I see
No,
Joe put in the. Go ahead.
I think we should keep everything else for part two.
Yeah,
We'll come back and finish.
Yeah, I see Joe put the handout in. There's two in there, the full slides and the 6 per slide. So thanks for doing that. We have a duty to monitor the nose. It holds the glasses. I had a patient. Yep, I agree. So yes, we're fitting glasses. Teacher opticians. I have my opticians come out all the time and say, "Hey, look, I know I've seen the patient, and the optician has brought the patient back after they pulled the hair back and said, 'Hey, doc, what do you think about this?' So get everyone involved, I guess, would be my 2 cents on that one. So So let me get to the end here. I think this will be part 2 of Anterior segment. I know I didn't get through a lot, but I think it was good conversation. These are supposed to be live and interactive and synchronous. So there was a lot of great questions that are out there. So let me see if I can share this again. And I'll just say thank you for being here tonight and great questions. I think we answered them all. Joe, any final comments before we wrap it up?
No, I think it was great. I like your choice of topics. I think it was broad and commonly encountered. No zebras involved in there. And I think you gave a lot of really good pearls. So if there are more pearls, I think we should probably come back in the future and do part 2. If you think, because I look like you've got quite a bit more material to talk about.
Yep, we do. I apologize for not getting through it, but again, sometimes we get the questions that say you go too fast, sometimes you go too slow, but hopefully there was a lot of pearls. So thanks, Joe. Thanks for the comments.
Mhm.